language is verbal communication, and so individuals with autism have problems with nonverbal communication. It's almost like they don't know there is a person to communicate with. So that's the difference between a language disorder, somebody who has trouble using language, and somebody that can't communicate at all. And then we have these repetitive and restrictive behaviors. And we used to have these different differentiations of Asperger's syndrome, PDD, NOS, and autism. But what happened is, when they developed the DSM-5, they said, well, those categories are really artificial. Those categories are really artificial. And one of the reasons is because communication is so entrenched in social interactions. If you have problems with communication, it's very hard for you to interact socially. And we found that it's hard to differentiate between those two. They overlapped quite a bit. And then what they found when they studied these different categories, Asperger's, autistic disorder, autism spectrum, PDD, NOS, they found if you looked over time, people went in and out of different diagnoses, so it was very unstable. So now we made a spectrum to say that children are on a spectrum with different severities in communication and social communication, so lack of social reciprocity, back and forth, a deficit in nonverbal communication, so that's like gestures, pointing, most importantly, and an inability to establish relationships. And somebody has to have all three of those deficits to be diagnosed with social communication issues. And then they must have two symptoms in the restrictive and repetitive behavior domains, either simple repetitive movements, need to adhere to routine, restricted interests where they can't get fixated on one interest, excessive reactivity to sensory inputs. And this is something new in the new diagnosis, realizing that there's this sensory component that we see in many children. But, and you have to have two of those. But what's most important is that these symptoms have to impact everyday functioning. So that's really important. So that means that if you have all these symptoms, but you're functioning normally as a normal person, you don't have autism. Okay? It has to impact you socially, because you see a lot of people, come up on TikTok, oh, I have autism, No, you don't. If you can make a TikTok video and do all these things, you don't have autism. You might have these features, and many of us have these features. Like, I know doctors have, like to adhere to routines, right? We have to have that little OCD in us, or we're not going to be able to, get things done quickly and, do the paperwork we need to do. Just because you have some of these symptoms doesn't mean you have autism. And so I think the best example of what communication defect is pointing. And that's where we always ask, when does pointing develop? Because pointing is the major communication method an infant uses. The first and the major communication method a child will use in the first year of life. And there's different types of pointing. There's proto-imperative pointing, where you point to something you want, that's simple type. And then there's proto-declarative pointing, which is more social. We point to something you're interested in because you want to share that interest with somebody else. Why don't we know a lot about autism? Why are we still discovering a lot about it? Because really it's something that's kind of new in medicine. Because if you look at the history of it, sure, Hans Asperger and Leo Kanner described this in the 40s. And then we have really the next big leaders in that, Bernie Remland, who took more of a biological point to it, and then Bruno Bethlehem, who really took a more psychological approach to it and probably set it back many years because of the way he thought. But it really wasn't until 1980, when we had the DSM-3, that autism was actually integrated into the medical diagnosis. So it wasn't until 1980 that medicine recognized this disorder and as diagnosable. And it wasn't until 1987 that Lovaas created ABA therapy as the first real therapy for autism. So really, in medicine, really that's kind of a blink of the eye. Now, of course, we have this problem here, where autism, as long as we have monitored it, the CDC has monitored it now for over 20 years, since 2000, and with almost every reevaluation, it has gone up over and over and over again. It continues to go up. So we won't talk so much about etiology of autism, what the cause is, but we'll talk about some ways of treating it. I like to focus on how we can treat autism and its comorbidities like epilepsy to improve kiddos' lives. So one of the things that's really paid off in the treatment of kiddos with autism and epilepsy is the disruption in folate transport into the brain. And so the brain is a protected area. Things can't just go in and out of it. There has to be these special carriers that carry everything in and out of it. And we have these disorders where these carriers don't work. One of the things that's important is the folate carrier. It sits on something called the choroid plexus, kind of in the middle of the brain. And folate comes in from the blood. It's transported across into the cerebral spinal fluid that surrounds the brain. And then the brain ependable cells have to take it up and put it into neurons. So it's a pretty complicated process. And here's kind of another kind of cartoon of how this works in a little bit more detail. We ingest folates. It comes in through two different carriers into what we call our portal vein, goes into the liver, where it can get transformed into different types of folate. The major folate that we use, 5-methyltetrahydrofolate, and that goes into the blood for use in the body. So to get into the brain, there's one major carrier called the folate receptor alpha, which you see here. Now the folate receptor alpha binds onto folate, and it actually actively pulls it across the cell and essentially dumps it into the cerebral spinal fluid. And this is a very active process because the level of folate in the brain is about 2 to 3 times higher than it is in the blood. So it couldn't just kind of diffuse across there. You have to have energy actually pull it up and dump it into the CSF. And so if this isn't working, we have a lot of problems. Luckily, we have this backup carrier called the reduced folate carrier, which also can bring folate across, but as you see, it's smaller because it doesn't like folate as much. You have to use reduced folate, and it doesn't really have this mechanism where it pulls it across so much. So it's less efficient. So about 2004, Dr. Rainmakers, who's a Belgian pediatric neurologist, and Dr. Blau, who's in Switzerland, Zurich, who's very famous for examining cerebral spinal fluid chemistry, found some patients that were not doing well. They had some developmental issues, particularly developmental regression in the first year of life. And they tried to figure out what was wrong with them. And what they finally did is they looked at the cerebral spinal fluid. They did a lumbar puncture, took out the fluid, and found that their folate levels were very low. And so at first, Dr. Rainmaker said, well, we know about the mechanisms that transport folate into the CSF. So why don't I look for mutations? Maybe it's a genetic disorder. and he couldn't find any of the patients have any type of genetic problem with the folate issue. He studied these first 20 patients. He found out that we could treat them with a special type of folate called leucovorin or folinic acid, which we'll talk about in a second. But then he teamed up with Dr. Quatros from SUNY Downstate in Brooklyn, and Dr. Quatros was actually studying folate from the point of view of problems with pregnancy and neurotube defects. And he had found that there's these antibodies that can bind onto this folate receptor and mess up what's going on. So they tested these patients, and they found out that they had these antibodies that were preventing folate from getting into the brain. And they published this paper in the New England Journal of Medicine, really defining this new disorder called cerebral folate deficiency. So these kiddos, as I had said, most of them had onset of symptoms before 1 year of age, and they had irritability, descending head growth, which we call acquired microcephaly. They had either standstill or regression, hypotonia, and then they developed neurologic signs like spasticity, like you see in cerebral palsy, movement disorders, epilepsy and seizures, and if they weren't treated, they can even have blindness and hearing loss. And then they showed, compared to control groups, that they had this very high titer of the folate autoantibody. So what does that do? Well, the folate autoantibody, there's two types. There's a blocking and a binding. And the blocking attaches to the folate receptor alpha and prevents folate from binding to the receptor to be brought into the brain. And the binding binds somewhere else on the receptor and just kind of messes with it, its ability to bring folate over and dump it out into the cerebral spinal fluid. So again, I said there's this backup system here. There's the reduced folate carrier, which we use. And what we could do is use high doses of reduced folates, one of them being 5-methyltetrahydrofolate, but other reduced folates go through here. And of course, this isn't as good as transporting the folate at high levels. So what we have to do is raise the folate level in the blood, so it's essentially pushed through the reduced folate carrier at adequate levels that will get into the brain and keep the brain with adequate folate. I'll take this second to also talk about the difference between reduced folates and oxidized folates, because it's very important. So we all think of folate as folic acid. That's what is in most of the products that we see. So folic acid does not occur in nature. It is a synthetic form of folate. Okay, so what happens is the body has to activate it. And we can go back a couple of slides just for a second. So we can see here in the liver, there's this one pathway here that says, or one enzyme, DHF. And this is, that's the folate, but here, DHFR, which is dihydrofolate reductase. So this is folic acid. It has to be reduced in order to become an active part of the body. So what does that mean? Well, some of us have, sometimes we have something called polymorphisms, small changes in the genetic code, which make this enzyme less efficient, so we can't reduce that folate as fast. And two, we only have so many of those enzymes. So when we think about folic acid, if we need more folate in the body, and we give more folic acid, and one, you have a problem reducing it, or we give a lot of it and you just don't have as many enzymes, you could think of as pipes, to get it to be reduced, it's going to build up. You're going to have all this unmetabolized folic acid. And what we're finding is that synthetic form of folate, the unmetabolized folic acid, when it gets high, it actually inhibits folate metabolism. So you can give all you want the reduced folates, the bioavailable folates, 5-MTHF, leucovorin, folinic acid, and they will not inhibit folate metabolism. But unmetabolized folic acid actually has a detrimental effect on the body. So it's not so easy when you think you need more folate to just take folic acid, because it's the wrong type of folate. Why do we use it? We fortify our food with it because it's very stable, so it will stay stable, and it's inexpensive. So just to look at the studies that have validated the work, of course, you say we see these, we've associated these antibodies with kiddos that have cerebral folate deficiency, but you know, what's the correlation? And there's a number of studies where we've actually correlated the CSF level of folate with the antibody titer. One of the interesting things is in autism, so this is in CFD, the normal level is about 40. So you can see in CFD, these are all very low levels. In autism, we can see that it correlates, but these levels are not below normal. They're in the lower range of normal in autism. And these kids do respond to leucovorin. So it's something we're looking at, but it does suggest that, I like to say that, you know, normal ranges are for normal people. So using normal ranges in a lot of things that we interpret labs is not always that easy, and that's why you have to go to a specialist that understands how these labs vary. So in any case, when cerebral folate deficiency was described, more people started publishing cases, and it was very clear that there was many cases that had features of autism. So myself and my colleague, Dr. Rossignol, said, hey, how many kids are running around in our clinic that have this folate autoantibody, because we might be able to treat them. And so this was our first study, and what we found is that 60% had the blocking antibody and 50% had the binding antibody. So at least 75% had one of the two antibodies. What we did is the kiddos that were positive, we knew that leucovorin or high-dose folinic acid is a treatment in the previous studies on CFD. So we prescribed it to these kiddos, and we asked the parents when they came back how the changes were in different features, language, stereotype behavior, and such. And then we had a control group of parents that were waiting for the results of the folate autoantibody and hadn't made any changes, and then we used them as what we call a waitlist control group to see how their kid changed over that time. And what we found, there were significant improvements in receptive language, expressive language, verbal communication, stereotype behavior, and attention. So this is what we call an open label trial. So people knew that they were getting the medications, so they can be biased, right? There's the placebo effect, so to speak. So next thing to do is a double-blind placebo-controlled trial. And so this was our double-blind placebo-controlled trial on kiddos with autism. And we keyed in on language because that's what seemed to change the most. What we showed in 12 weeks, there was a significant improvement in language with leucovorin, or also known as folinic acid, with the treatment as compared to placebo. We were also, since we had all comers, we were able to ask, does the folate receptor alpha actually predict who is going to respond or not? And we found that it did, that those that were positive for the antibody had what we call a very large effect size, and the number needed to treat is 1.8, which is a very good number. You know, we don't realize in clinical trials many times the number needed to treat is somewhere about 4 or 6. Now, what does number needed to treat mean? That's how many kiddos do you have to treat in order to get the effect. So a lot of people don't know because they think you go to the doctor and they give you a drug, right? You think the number needed to treat is 1. They give you the medication and you get better. But it ends up in clinical trials at somewhere around 4 to 6. So you have to treat 4 to 6 patients to get the response. So 1.8 is a good number. It says about 60% of the children will respond if they're positive. We also looked at the number of hours that this would be equivalent to as far as speech therapy for language. And it's equivalent to about 130 hours of speech therapy, which would be hard to do, even in a year. And then there was a second study from France that looked at change in autism symptoms using the gold standard called the ADOS, and they also showed in this trial, which was single-blind, that there was improvement in autism scores with leucovorin or folinic acid. We also know that this is a whole other subject, but we know that kiddos with autism have methylation and redox abnormalities, and looking in the brain, these exist in the brain, not only in the body, and that treating with leucovorin normalizes all these measures of methylation, which is great. So the question is, of course, how many kids with autism have the antibody? I told you about our one study, but this is a study we did which is called a meta-analysis, where we take all studies that have been done together to see what they say. And so kids that have the folate autoantibody who have autism is 71%. So this affects quite a few kiddos. And those that have CFD, so frank CFD, where the level is actually below normal, is 38%. So that's a good number of children with autism. And so you remember I told you that one of the symptoms was seizures. And so then we did another meta-analysis where we looked at what was the improvement in certain symptoms with leucovorin. And for those with autism and cerebral folate deficiency, 75% of them had an improvement just by giving leucovorin. So not another anti-epileptic medication. So that tells you that we have a treatment that's a non-pharmacological or non-anti-epileptic drug that can improve epilepsy in kiddos with autism, and those other ones with cerebral folate deficiency too. They only had a response of 54%, but still that's half. That is rather non-toxic and usually well tolerated. Since many of the AEDs sometimes are not very well tolerated by kiddos with autism for many reasons. There's other types of disorders, and this is an example of a disorder called dihydropyridine reductase deficiency, where there's a problem in recycling something called BH4, which is very important for making neurotransmitters and breaking down phenylalanine. And it ends up, if you give more folate, you can actually use an accessory, what we call a salvage pathway, to get around that. So these kids have terrible seizures, and just by giving high doses of leucovorin or 5-methyltetrahydrofolate, which is derived from leucovorin or folinic acid, so either one, you can activate the salvage pathway and reduce their seizures significantly. We've seen these in other cases, and these are 2 cases of kids with mutations in the folate receptor. And these are interesting cases because this is an 8-year-old child, the first case, with developmental delay who suddenly develop these very severe, what we call myoclonic seizures, where he drops to the ground more than 50 times a day. And these tend to be very, very difficult to treat. He developed these at 7 years old, and they tried all types of anti-epileptic medications. And it wasn't until he was 8 years old that they found this mutation and started to treat him with leucovorin, in this case intramuscularly, and it improves seizures significantly, his unsteadiness, his ataxia, and his social interactions. The second case is interesting too, because it's a 12-year-old with developmental delays who suddenly developed these seizures at 6 years of age. They didn't discover until he was 12 years that he had this mutation, and then he treated them. And he didn't respond as well as the 8-year-old, maybe because treatment wasn't started earlier. So this is really important when seizures don't respond, to anti-epileptic medications. It's very important that you can use it may be that a simple and safe treatment. And I'll be coming out with a book called The Folate Fix, which describes all this about how we can use folate to really enhance health, including seizures and other things in children with neurodevelopmental disorders. So one of the other new things to change gears that's really developing is something called photobiomodulation. And it's a really interesting technique. We have all different techniques that may be helpful for neurologic disorders, including epilepsy. And two I'll talk about is transcranial electrical stimulation and photobiomodulation. So we can actually take a near-infrared laser and shoot a certain frequency of light. It's important because it has to be a certain frequency of light. And many of this you see on Amazon and such. They call this, red light therapy. You have to be careful because, it may not be tuned to the right device, right? The infrared light looks red, but it's at a much higher frequency than the red color. So, so there's devices that are good, and devices that are not so good. So you have to really work with your provider for this. And it ends up that this light actually does get through the skull and can activate the brain. And what it activates, this red light, activates something called complex 4 in the mitochondria. So the mitochondria, I should have given a little bit of background, is the powerhouse of the cell. It's where we get all our energy. We know that it doesn't work. It's very sensitive. Sometimes you can have mitochondrial disease, where you have gene mutations that hurt the mitochondria. But the mitochondria is also very sensitive to environmental and outside agents. So it's very sensitive to inflammation and oxidative stress, and it won't work all that well. It sits in the middle of what we call metabolism, how your body makes its fuels, it breaks down its wastes, and such. So anytime there's a disruption in metabolism, which we see in many disorders, it will affect the mitochondria. Anytime the mitochondria doesn't work, it will affect the rest of the metabolism. Mitochondria seems to, what we call mitochondrial dysfunction, seems to be seen in epilepsy, many neurologic disorders, and autism. So we need a way to get more energy, and this actually, photobiomodulation, will stimulate this complex 4. And the important thing, so these are what we call the electron chain